Hi, I'm Ravi Mehta, a nephrologist at the University of California, San Diego, and I'll be talking today on renal recovery patterns influencing mortality in the ICU. This is my disclosure information. As you can see here from this slide, over the last several years, we have knowledge of acute kidney injury influencing outcomes, both with respect to hospital length of stay and mortality and de novo development of chronic kidney disease. As a consequence of this, the ADKI had a consensus statement in 2017, which showed that you can classify AKI in the first 7 days and CKD after 90 days with the intervening period labeled as acute kidney disease. But what's most important is to recognize that there are several patterns of following an episode of acute kidney injury. For example, you might have a rapid reversal and return to baseline. You might have patients who have some initial improvement and then have another episode and then decline, versus those who never recover and those who have underlying chronic kidney disease have a course which is different from any of these other ones. And as a consequence of this, the ADKI suggested that we would classify these patients as persistent acute kidney injury or as having reversal within a 48-hour time period. Now, this has led to further studies, and this is a recently published trial from the ASSESS-AKI trial in the United States, where they were following patients with kidney injury in the hospital for a long period of time following their discharge. And as you can see here is the development of major adverse kidney events defined as development of chronic kidney disease, death, dialysis during the course was quite different in those patients who had no AKI, had AKI which resolved versus non-resolving AKI. The same style for episodes were seen in the ICU population from a study published by John Kellerman Group in Pittsburgh, where they looked at a study cohort of about 17,000 patients and categorized them with respect to those patients who had early reversals versus no early reversal. And as you can see here is there's a differentiation in terms of death or dialysis requirement with these different patterns, with the worst outcomes in those patients who had never reversed or had a relapse with no recovery. Now, we know from the cumulative data so far in the literature that the timing of onset, the severity of injury, the duration of injury, recovery, and transient injury and recurrent episodes are all associated to some extent with short-term outcomes. But we don't know as much in terms of recurrent episodes. What we do know is that the underlying kidney disease and the fluid status influence mortality. So with these questions in mind, we ask the question is, do the renal recovery patterns in AKI influence mortality, particularly do the episodes and the pattern overall change? And these are my colleagues. This is Dr. Macedo from San Diego, Dr. Osterman from the UK, Sheeta from University of Alabama, Dr. Zarbach from Munster, and Dr. Bouchard from Montreal. Our objectives were to look at the pattern of renal recovery after AKI and on mortality, and we assessed the hypothesis that AKI course and duration would influence the length of stay and mortality. So a retrospective multinational cohort in the 4 centers collected from between January 2014 and 2017. They were hospitalized acute kidney injury patients, and we excluded those patients with kidney transplant, end-stage renal disease, or ICU less than 36 hours. Our stratification of the patients were those who never had AKI, and AKI was defined by serum creatinine KDIGO criteria. Those who had one single episode of AKI versus those who had a stuttering course with multiple episodes of AKI, and defined a recovery that where the last recorded serum creatinine was equal to or lower than the patient's reference serum creatinine, whereas the no recovery was patients who had AKI and last recorded creatinine was higher than the patient's reference creatinine, and the outcomes were ICU and hospital mortality. These are the patient characteristics, and I'd like to point out to you, here is the large group of about almost 10,000 patients with no acute kidney injury. As you can see, comorbidities were quite similar, with diabetes in about 17%, liver in about 21%, and here, as you can see, there was no episode of acute kidney injury. The single episode group, there is similarities with those with a stuttering course. So about 2/3 to 3/4 of these 10,000 patients is with single episode versus about 1/4 of them have a stuttering course. And you can see here is that there's a significant difference in terms of how many patients are dialyzed with those stuttering course versus those who are not, and some differences in terms of the comorbidities. But when we ask the question is, amongst these patients who have a single episode, if you classify those with no recovery versus those with recovery, as you can see here is there is a difference with respect to the frequency of dialysis. There is about 10% versus 14% dialyzed here. There's not much of a differentiation in the stage of AKI that's reached or much in terms of the comorbidities itself, a slight difference in the age. In contrast, when you look at this, the stuttering course, again, age becomes somewhat of a factor. But what you do see is that there is a significant difference with respect to those patients who are dialyzed, almost twice as frequent in those patients who have no recovery in contrast to those who do, and some differences with respect to the stage of AKI, with a little more in stage 1 who have recovery in this setting. So when we look at the relationship of this course on the patient's outcome, here's the total cohort, no AKI in AKI. Overall, about 26% are stage 1, 16% stage 2, and 11% in stage 3. Total of this of the total course itself, and it's about 74% single episodes in stuttering course. But notice that ICU mortality in those with single episode is lower, as is hospital mortality, in contrast to those patients with a stuttering course. When we look at this a little further, and now look at what happens with respect to those patients who have no recovery in these two boxes here, in the single and the stuttering, versus those who have recovery in these two boxes here. What you notice first is in the single group, you can see the ICU mortality is almost threefold higher in those patients who have no recovery when it is a single episode. When you look at the same contrast here in the patients who have no recovery versus recovery, a similar pattern in the stuttering course. But when you compare the overall mortality in those patients who have recovered in the stuttering course versus recovered here, you can see again a difference in the mortality rates, those who have recovery in the stuttering course versus those who have in the single course. Therefore, representing that these two patterns are distinguishing how these patients might behave. And the same thing is associated with the length of stay. Here, for example, is the hospital length of stay and the ICU length of stay is quite similar in patients with single episode, but is markedly different in those patients with the stuttering course, again representing that the pattern here, the more episodes you have, the more longer you're likely to stay in the hospital. We do a survival analysis on this, this becomes even more apparent, where the patients are censored both with respect to death or discharge from the ICU. And you can see that just at a glance, these worst courses are those patients who have no recovery. So there's no recovery at these two patterns here. This is the group which have no AKI. And again, the numbers go down because they are discharged earlier. And then those patients who have a stuttering episode of acute recovery take longer to get down there. But this is in terms of death. We look at the same patterns for death or dialysis. It is similar in this aspect. So when we apply this for a multivariable logistic regression for renal recovery, and ask the question is what are the features which are associated with renal recovery, we can see that there is a relationship in terms of the severity, but to a large extent, if you are dialyzed, you have less chance of recovery. The maximum SOFA score, the requirement for vasopressors and mechanical ventilation all influence this, although mechanical ventilation is not significant in this analysis. And when we ask the same question with respect to the multivariable logistic regression for ICU mortality, we find that there is a relationship of age, the stage of AKI, and the requirement of dialysis influence for ICU mortality, and as does the underlying severity of illness with maximum SOFA score, requiring vasopressors. Again, mechanical ventilation does not appear to be responsible. But when you look at the interactions with respect to no recovery or recovery, these are associated with the interaction terms which will influence these patterns. So in general, in summary, what we are finding is that recovery from AKI in the ICU is heterogeneous, and the pattern influences resource utilization and mortality. The number of episodes here exemplify the starting course significantly increase the dialysis frequency. They prolong the length of stay in the ICU and the hospital stay and increase mortality. And in general, patients who do not recover from AKI have a worse outcome. So it is possible that we could start thinking about these phenotypes to identify patients who are amenable to therapeutic intervention. And most importantly, these subphenotypes may help us target those patients so that our goal simply should not be just to support patients with AKI, but to try and optimize AKI by enhancing recovery as much as we can. So hopefully our study will lend further to the growing evidence that we need to focus on renal recovery following the ICU and not just simply on identifying these patients. Thank you.